Good afternoon. Thank you everyone for coming. Welcome back to Multi-Modality Imaging Conference. I'm Man Malafchi, and today we're going to talk about aortic regurgitation, quantitation by echo as well as MRI. So we'll cover mechanisms of AR, we'll cover echo and MRI, grading of severity as well as assessment of LV remodeling, and some of the newer outcome studies that came out particularly on these topics. And then we'll have case examples mixed in as well as towards the end of the talk. When looking at the anatomy of the aortic valve, particularly as it relates to aortic regurgitation, as you all know, the aortic annulus is this virtual ring that's not a specific anatomical structure, but it's at the basal insertion point, or that virtual sort of circle that gets at the insertion of the leaflets. And then the actual junction between the aorta and the crest of the ventricle is higher up, actually above the insertion of the leaflet. When it comes to AR, you can have abnormalities of the leaflets as well as the annulus level, and then importantly also the wall of the aorta as well as the SCJ. All of these components can become abnormal or deranged and contribute to development of AR. And many patients, as you'll see, will actually have multiple etiologies for AR, so it's not just one single cause. This is kind of the current scheme of grading or deciding the mechanism of AR, and this kind of follows the evaluation for mitral regurg. So we have a Carpentier class 1, class 2, and class 3. A lot of class 1 is aortic root abnormalities or SCJ abnormalities. You can have isolated dilation of the root with minimal ascending dilation. You can have dilation of the SCJ where it actually pulls back the leaflets and interferes with coaptation. And then the less common cause in class 1D is perforation of the leaflets, such as in endocarditis. Type 2 is one of the patients that you don't really want to miss. This is important for both echo reporting, but more important also for deciding on management. A lot of these patients can get AV repair, and you don't want to say, oh, this is just severe AR without more description of what's going on with the leaflets. As you may suspect, the more common patient population in this category is people with bicuspid valves, unicuspid valves. And then type 3 we're seeing more and more of. These are now the older patients in their 60s and 70s. They can have degenerative valve disease and calcification, maybe in combination with aortic stenosis or prior exposures. And these patients are kind of the predominant type that's now being evaluated for transcatheter intervention. The reality is, as opposed to mild TR or mild PR, which all normal healthy individuals can have, it's unusual to have aortic regurg without an actual abnormality. Even mild AR is unusual. So whenever you see AR, even if it's mild, you should actually take a closer look at the leaflets and the aorta. And for many of these patients, you should still actually follow them, especially if they're older, because these can actually progress to moderate and severe disease. So there's a long list of causes of AR. The big categories are a leaflet issue, so people with bicuspid valve, endocarditis, degenerative disease, like I mentioned. A big category of dilation of the aorta, either one of the components or multiple of them. And you can have also things like dissection and inflammatory conditions like aortitis, etc. And then you can have both. And then we see a lot of these patients, so you should always consider this. Now, grading of AR is very, interesting to me, and we spend a lot of time doing this in the echo lab and on the research side. I try to kind of categorize it a little bit differently. There's so many measurements. It's a little bit more than what you have for aortic stenosis, for example. So there's ways where we can try to infer or directly measure the actual orifice or the defect that's causing AR. So these are things like the regurgent orifice area, the vena contracta, and then looking at the jet itself. There's ways to actually directly measure the volume overload, so you can see how many cc's are there. And then there's multiple ways of doing that, whether it's with PISA, with Doppler, or with MRI. You can try to get the physiological sort of angle and try to see the hemodynamic effect of AR. So these are your tools such as pressure half-time, flow reversal. And then you can actually look at LV remodeling. For chronic AR, you really have to look at the left ventricle. It's not just looking at what's causing the valve issue, but it's also what the result of it is. And then this is kind of what I like to call a bonus feature, is determining or finding if the person has a high flow state. AR is a high flow state. If you examine these people when they're severe, bounding pulses, rapid deceleration, big hearts. So the LVOT TVI kind of gives you that. And this is something you should pay close attention to on the echo. So this is kind of the guideline that we have. This is from 2017. As you know, it's guided or sort of gauged towards finding specific findings, things that we know associate with terrible disease and things we know that we associate with mild disease. So if you have a big flail valve, if you have a hole in the valve, if you have a very wide jet that takes up the entire LVOT, if you have a large flow conversions, rapid deceleration time, all these are features that are specific for severe AR. And then if you have a tiny little thin jet that is central, this is specific for mild AR. So determining these is not always difficult, but the challenge is when you have less of these specific findings, but you don't have these, and you're kind of in that moderate zone. This is where you have to really lean harder on quantitation. And quantitation, which we'll get into later, tries to look at regurg volume and fraction and then ERO to try to put the person, are they in the hemodynamically significant range? This is kind of that 3+ range, which you should always really consider to be significant or severe. Or is this the moderate AR that you have to monitor? Big emphasis is on, if you're unsure, don't be afraid to be unsure. There's always consideration for additional testing. It's much better to test the person with either TE or CMR than just say, hey, to me it looks like it's moderate, I'm just gonna call it moderate and move on. So this is an interesting survey from earlier last year where they surveyed multiple centers and countries, primarily in Europe, and they looked at which lesion is more considered difficult or considered the most difficult for quantification. So AR1, 42% of respondents thought it was AR that's the toughest. 10% said all are easy, and then aortic stenosis and mitral regurg were really fairly equally distributed. More importantly is when we'll go through all of these things, the pressure half time, the vena contracta, all these parameters, but then look at what the respondents said in terms of how many of these are they actually measuring and how many are they reporting. So things like 3D vena contracta is a very small minority. Regurgitant volume and ERO, even in the severe cases, is only about 60% of patients that people are kind of measuring and reporting these. And then for volumes, even whether it's MRI or TTE or CT, it's really a small percentage of people. And then look at the diameters. I mean, we've been using diameters for AR and MR and others since the 80s, but it's really only now that we have maybe a slight majority using the basal diameter versus maximal diameter. So the end result of all of this is that there is a lot of room for improvement. All right, so let's go through the specific parameters. So this is the vena contracta. A key thing is you have to actually show the 3 components of each jet. For each jet, there's usually an actual flow conversion zone, a vena contracta, which is the narrowest portion of the jet, and then the remainder of the jet. The vena contracta is actually a concept from fluid hemodynamics. This is the area where the column of a fluid is the narrowest, and it actually happens distal to the orifice. I learned this later on, but essentially, when you have columns of fluid that are going from a larger cylinder to a smaller cylinder through a hole, they continue to be sort of constricted, slightly more distally to the actual anatomical orifice, and the narrowest portion is actually just slightly distal to it. The end result of this is that the effective orifice area and the vena contracta are actually a tiny bit smaller than the anatomical area. So when we measure this on CT, on MRI, this is actually larger than what you'll have here. Now, when measuring this on echo, you have to be really perpendicular to the actual jet, ideally. You can still use it for eccentric jets, and the challenge for the sonographer here is trying to find the view, whether it's personal long or apical views, where you can actually get a very nice alignment of the jet so that the vena contracta is actually perpendicular. So if it's an eccentric jet, it may actually be more doable from the apical views, And then if it's a central jet, you can really easily do this from parasternal lung. The advantage of this is that it's independent of flow and driving pressure. It's not as dependent on technical factors. You know, it's an easy, nice way to decide mild versus severe. But like I said, you know, you have to have all the components of the jet. Notice with AR in particular, you know, the flow convergence has these kind of two heads. Notice the blue and the red. This is the flow convergence zone. If you look at it, you know, parallel to the actual ultrasound beam, you usually get a circle, right, for MR, etc. The reason is here is because you remember with Doppler, when you have a phase shift that's perpendicular, remember that angle thing with the physics equation? So this area is black because this column of blood is directly perpendicular to the ultrasound beam, so it doesn't show a velocity because the number from the equation is 0. Does that make sense? So watch out for this kind of double head for aortic regurg. And, you know, we've done some work recently on trying to measure this to just kind of get an easy and cheap way of measuring PISA and flow convergence as opposed to doing, you know, the full PISA acquisition. But for vena contracta, don't measure here. Don't measure here. You're going to try to find the thinnest one you can find. Okay? You don't need to adjust the baseline. You don't need to do anything. This is a simple measurement that is more reproducible than others, not very highly reproducible between readers. But it's all going to come down to the acquisition usually. So the sonographer's role here is even more important. So you get an example like this of mild AR, but you can also get an example like this where you have a highly eccentric jet. And here you may be able to measure the vena contracta if you zoom in and you try to adjust this, but you may be better off trying to do this from the parasternal, from the apical views. And then you can get examples like this. Would you guys measure the vena contracta here? Why and why not? So there's a lot of shadowing, right? You see how the valve is thickened and calcified, and we don't really have a clear demonstration of the entirety of the jet. Notice how it changes throughout diastole also. So I can give this scan to 10 other people, and I'll probably get different numbers for vena contracta, right? So we want to try to get as reproducible measures as we can. Now these are kind of the other two key parameters, the jet width and the jet area. The jet width is the area distal to the vena contracta, and you usually compare this to the LVOT diameter. So it's kind of a simple sensitive screener for AR. You can have a narrow jet and you're done. You can have a huge jet and you're also done because it's severe. But if you have an eccentric jet, you can underestimate severity. If you measure all the way out here, well, you can get a diameter that's like 60% of the LVOT. And obviously, if you have an LVOT that is very wide, this whole percentage thing is not as feasible. So as you see when you're reading scans, you know, we look at this qualitatively, but I've never tried to measure this and reported it as a percentage of LVOT diameter, and I don't think we should, at least not systematically. The jet area is also kind of in that category where we look at it, but we don't necessarily measure it routinely. But I show this particularly to kind of raise attention towards a lot of AR patients can be simple like this, but you can have also a malcoaptation where you have a whole lot of AR through here, and I'll show you examples of this. You can have AR that just is just between two of the leaflets, and it's a highly eccentric jet. The reason that this is relevant is if you capture the parasternal lung at this side, as opposed to capturing through here, you can completely miss or not show the entirety of the AR jet. So when you see AR as you're scanning patients, you should really do a very nice sweep and try to capture where their largest jet is for either vena contracta or jet width or any of these other parameters. So you should always, keep in mind, 6 millimeters or greater is severe, 60% or greater is severe for the jet width and the jet area, but these are more qualitative signs. So these are the three examples that I showed you earlier. Would you guys use the jet width here? You think it'll overestimate, underestimate, accurate for AR severity? So measuring the jet width here, comparing it to the LVOT. It may underestimate, right? And then this patient also, I honestly wouldn't measure the jet width here also. this patient needs more acquisitions, essentially. I'm not showing it to you so that you can decide, oh, this is severe versus moderate. Okay, let's talk about ERO. So the EROA is the third key parameters to try to infer or measure the orifice area. And as you know, we do what we call a proximal isovelocity surface area, where you shift the baseline in the direction of the jet, and you try to form, or more accurately, demonstrate a hemisphere of flow, of the flow convergence. So who can tell me what aliasing is, first of all, because we don't review this very often. So what does it mean for me to shift the baseline and demonstrate aliasing between, two sides of the, at the surface between the hemisphere and the circle versus away from it? What is all of this even? Uh-huh. Uh-huh. Yes. I can tell you're starting on those echo boards. So with the echo, so this is sampling theory, and it's also not an echo concept, but it's applied to echo. So when you have with color Doppler and by extension pulse wave Doppler, both are the same thing. You have a limit as to what velocities you can display. And this is mediated by what we call the pulse repetition frequency, like Saliha was saying. So at a limit, you can actually have aliasing where the measurement appears in the opposite direction. So the equivalent of that on echo Doppler is you can have a change from red to blue or from blue to red. Now, what we're using this for is as the jets of flow are getting closer to the orifice defect, they actually form these sort of hemispheres of flow. Think of a huge stadium with a whole lot of people trying to get out of one room. Towards the end of the stadium, you may have a stampede, but they all kind of form in a circle because they're all trying to get out. And then the velocity changes as you get to the small area. Key equation in echo, flow equals area times velocity. So as the area gets smaller, the velocity gets higher, right? And this is why you get the highest velocity at this range. But we're trying to determine this area. And what we do is we manipulate the color Doppler to try to show us where this hemisphere is that gives me a velocity of 40. I just picked the number 40. So we pick a number 40 because I know that I can use that number for the equation. And then I show the hemisphere where I know the velocity here is 40. So if I know the velocity here is 40 and I know the area because I can calculate it by the radius, then I can just rearrange this equation to give me the area of the ERO. So velocity, aliasing velocity, V1, and then area is the actual Pisa equation for the hemisphere. And then peak velocity for aortic regurg is that peak velocity at early diastole, so at the beginning. Notice that it's only using the peak, so it's not really accommodating or accounting for what happens towards later in diastole. But you're just interested in finding out the biggest size or the largest size of that hole, which is the smallest hole. Does that make sense? So long story short, this is a way to try to measure the orifice area. The challenge is if you can't get a full hemisphere, if you have an eccentric jet, if you're not very good at this, if you haven't done it very often, if you have a small error, you all have tried to measure this. You can measure it multiple times and you can get slightly different numbers. When you square this number, it compounds or compounds the error further. So these are kind of some of the challenges for this, and it's for AR. It's a little bit less feasible than it is for MR. The average in the papers has been in the 60 to 70% range. So you can't really use this for everyone. But the physics concept, holds. The challenge is finding patients where you can apply the physics concept accurately. So when you have an eccentric jet, like this guy, you can actually do it from here. It doesn't have to be from the apical views. You can actually get it from parasternal lung. You shift the baseline, and then the sonographer here has to really maximize all of their adjustments to try to get a nice hemisphere. There's corrections for the angular or for those eccentric jets, but they're not really used routinely. So this is an example of this. Notice this patient with prolapse of this right-sided leaflet, then highly eccentric AR. You can measure the width, and then you can shift the baseline. You get a hemisphere. You measure, or you decide what the aliasing velocity is. You measure the radius, and then you can derive not just the size of the orifice, 0.3 is severe, but you can also derive the regurgitant volume by integrating the flow rate from that TVI that I showed you earlier. You can also do what we call a vena contracta area on 3D echo. This is still primarily in the research side of things, but this is just another way of measuring the orifice area. Okay, other semi-quantitative parameters, so we'll talk about pressure half-time. The pressure half-time concept is trying to display the interaction between the aortic pressure and the diastolic or the LV pressure during diastole. And it's known that when you have severe AR, this is on cath, you can have rapid equalization of the LV diastolic pressure. And then from this cath study, this is, I believe, the earliest one, it correlates pretty well with severity of AR as measured angiography, on angiography, as well as quantitation by angiography. But the challenge is, notice that there's a pretty wide spread of values. And as you may suspect, a key parameter that modifies this is your aortic diastolic pressure, your LV diastolic pressure, your LV stiffness, your LV compliance. All of these things are not really related to the orifice, right? So pressure half-time can be pretty good for specific patients. It's kind of these rare acute AR. We can have a very short pressure half-time, and you may not even see AR on color very well. But for chronic AR, if you're trying to decide these moderate versus severe, it's not very good. And then essentially, at the extremes, you can use it to gauge, mild versus severe. Flow reversal in the aorta, as you see, the column of blood reversing back in the aorta, we can measure this on the descending aorta, and we can measure it in the abdominal aorta. If you have holodiastolic flow reversal, and usually people say it has to be more than 20 centimeters per second at the end diastole, it's a specific sign for significant AR. And the closer or the farther out you are to the abdominal aorta, it becomes one of those measures you can take to the bank. In rare cases like someone with a fistula or a ruptured sinus valsalva, you can have flow reversal without AR necessarily, but I've never seen a ruptured sinus valsalva be misleading for AR. Okay, now this is full-blown quantitation as along with PISA. So you can measure the flow in the aorta, and you can measure flow in the mitral valve, and because you have aortic regurgitation, this flow using diameter and TVI will be higher than this flow in the mitral through the mitral valve. The challenge here is measuring the mitral valve annulus, prone for error. The error is squared, and this actually works. It's just at a higher variability. And then 60 mLs or greater is considered severe. You divide the 60 mLs by the aortic forward flow to get the regurgitant fraction, and currently considered 50% is considered severe. What if you have concomitant MR, or if you have a concomitant shunt? Can you use this? Yes or no? Well, I'm hearing no. So if you have concomitant MR, flow here will be higher, right? So you can't really use this because it's confounded. And if you have a shunt, obviously you can't really use this. But if you have isolated AR, you can. Now, if you have concomitant MR, you can still measure flow in the aorta. So TVI, diameter, you get stroke volume of 124. You can measure the RVOT diameter. And here you can kind of use the color to help you. And you use the TVI of the RVOT, you get 47, and then you subtract one from the other to get the regurgitant volume. What if you have TR? Would this still work, or would it be compounded or confounded? It still works because for TR doesn't modify this equation. But if you have pulmonic regurgitation, you can't really use this. Uncommon for us, so I tend to use this more for quantification. Key thing here on the acquisition, you have to really get nice RVOT diameters. And obviously, you know, we know that the RVOT is also not circular, so there's still assumptions that go into this. You can even do this on TEE. So this is a TEE. You show from the transgastric view, you show the RVOT, and you compare the two, and you get regurgitant volume and fraction, and you use all the ancillary findings. So these are some case examples that kind of highlight some of the issues with just eyeballing it, essentially. So this person has 5.9 centimeters, so mildly dilated, and then here's his AR jet. Here's hers, or his or hers, I can't remember. So first of all, what do you guys think is wrong or could be improved with this acquisition? You mumbled it, I couldn't hear you. You could chip the color baseline, but before that, notice how the time resolution or the frame rate is very rough. I can't. Yeah. So you have to make the box smaller so you can actually get a nicer frame rate on color. We see that there's a jet, but we have no idea where the jet is starting, what is happening to it, and then after we kind of optimize the jet, so you zoom, you shrink the box. I'm not interested of what's happening here. Where's my mouse? I'm not interested in what's happening here. I'm not interested in what's happening here. I only want to focus on what's happening here, and then you sweep. You show the origin of the jet. Then you can start making measurements, and then yes, you can shift the baseline from this. We can tell that there's something, it's eccentric. We can't really make much beyond that. So this is kind of how the jet looks, and it literally took me just this frame to get this picture. So here's, I'm not going to show you. Yeah.
A big box like that, what's the range of temporal resolution versus a small box?
You know, it displays it here on the upper top, what you end up with. But it's highly variable because it's, you know, it's the size of the box and it's the depth. So I don't know off the top of my head what numbers you get. But I mean, this you can, I think this just visually it looks almost like 90 or 100 milliseconds. It's it's almost like you're just getting 3 pictures of color.
Your goal is to get what temporal resolution?
I mean, on these kind of acquisition, it goes down to like 10 megahertz. So I mean 10 hertz. So it's very good temporal resolution for this. 1 divided by 10, like 10 milliseconds. But
so
we.
Is that one of the parameters sonographers look at?
I don't.
As much coverage as I can, it's a trade-off.
Yeah. Well, what we do is. And the sonographers can add to this, you know, in our protocol, what they usually do is they get you a big sort of overview of the left ventricle, and then they put a big box on the aorta, on the aortic and the mitral valve, and then if they see something, then they zoom in and they focus on it. If they don't see anything at all, they may just suffice by this. So it becomes a little bit dependent on the patient. But you see examples like this, it could be missed, essentially, if you're not paying attention. With just a big box that doesn't cover. There's advantages to the big box. If there's a VSD, you could miss it if you're only looking at one specific thing. Okay, so I'm not going to show you everything, but this patient, notice, has flow acceleration through the descending aorta, as well as flow reversal. And the report said LV size is normal, which we're not really sure. Mild to moderate AR, we're suspicious. Early evidence of aortic valve stenosis. This is always a sort of an alarm to be watchful for. For these AR cases, they can give you high velocity, but doesn't necessarily mean that there's actual stenosis. So this is inadequate, essentially. I'm showing you this not to kind of give you the end of the or what the qualifications or the acquisitions should look like, but just to show you that there's alarming findings for LV size and flow reversal that suggest significant AR. There may be a mild coarctation, but the color acquisition, we need to do better with it. So this person had a TE and an MRI, and she had a monocuspid aortic valve with wide open AR and prolapse. All right. Here's a third example. So what do you guys think of this jet? Frame rate is not so bad. You can always say we want more images. So we see AR. Do you think it's definitely mild, or could there be more to the story? So we see AR, notice how it varies from beat to another. This is that sweep that becomes relevant. And we actually see a bit of a convergence zone, not very dramatic, but when you see a convergence zone without even shifting the baseline, you should be careful. So here's how it looks on the apical view. If I showed you, I'm taking too long. Well, what I'm trying to show an example of. So notice big convergence zone. I was trying to show you an example of the jet height. So be careful with the jet height actually showing you a whole lot of color in diastole. That doesn't necessarily mean that it's severe disease. There's entrainment and changes on color Doppler that essentially can make the jet height appear more impressive than it is. And that's why you should not really go by what's happening here, but actually go by what's happening here. So notice how there's a sizable convergence zone without even shifting the baseline. Here's your pressure half-time, and here's that finding that I told you about earlier. Big TVI in someone with high velocity and high flow. And we did further quantitation on this. This was kind of closer to the moderate range. So that's the key thing to watch out for, essentially, the flow convergence and then the TVI. So where's MRI add in this kind of situation? So we have an independent assessment of volumes, which is highly validated and highly reproducible. And we separately measure flows. So we do these phase contrast acquisitions, and you can do one just above the valve, and you measure what's happening forward and then what's happening during diastole, and you can directly integrate this to get the regurgitant volume. Just like we do on echo, you can compare the flow in the aorta versus the flow in the pulmonary artery as a secondary check, and this really gives an advantage to MRI because you have multiple ways of checking this and ways to verifying that your measurements are correct. And as a result, these are highly reproducible. Unless there's an issue with the acquisition, all you're doing is drawing a circle. So you can get within 4 to 5 cc's if you give the same study to 10 people. And as you see here, compared to echo, the inter-observer variability is very small compared to echo quantitation. And we did this study a few years ago where we looked at people with isolated, moderate, or greater AR, and the regurgitation severity as well as the remodeling extent parameters were a little bit lower than what you would find. And this is a key message that really applies to both echo as well as MRI. Once you have values that are in the moderate to severe range, this is hemodynamically significant. So don't wait on that regurgitant volume of 60 cc's and the regurgitant fraction of 50%, particularly for aortic regurgitation. Once you're in the 40s for regurgitant fraction, this is significant. And the guidelines now on the ESC side go by a regurgitant fraction of 40% or greater as being significant on MRI. Now, these are going to be re-evaluated. In reality, this is just extrapolation from mitral regurgitation data. So when you actually do all the quantitation that I showed you, it may actually be that these values are also a little bit lower in terms of what values associate with adverse events. The regurgitant orifice area is probably solid at 30 millimeters squared. Okay, so here are some other case examples. So the 32-year-old with a heart murmur, and then you see a jet. You don't have all the components, but it's not mild, right? Do you guys agree? And it's mildly or somewhat eccentric. So you're going to ask for more images, and you see a bicuspid valve with fusion between these two leaflets. And this is what I wanted to show you earlier. If your acquisition is done like this, you're going to get a wildly different jet area than if your acquisition is done like this, and obviously if it's done like this. So this is part of the challenge with the repeatability and reproducibility of some of our parameters, and you have to take into account the whole thing and the fact that not everyone will have a small circular orifice of AR. Some people will have jets that go along, and this patient had, a focal prolapse of that leaflet. Here's another example of prolapse. This is from the literature. Notice huge prolapse of the posterior leaflet without even shifting the baseline. You get a convergence zone and a huge jet. Here's an example of endocarditis. So large appearing LV. Same thing, notice that big box. We don't really see much here, but we know that there's AR, we know that there's MR, but It's not showing us the entire picture. And here is really detecting the vegetation. So here's a vegetation, and then here's also a vegetation or an issue on the mitral valve. And this heart is huge, as you can see. On TE, he has complete destruction of the aortic valve as well as the mitral valve with a perforation here, and this is kind of what we call an aneurysm of the leaflet. So this is kind of a typical scenario that you can get for these patients. Notice the destruction here on the aortic valve is also not necessarily going to be a small circular hole or a circular hole. Notice how you have what probably is a perforation along this line. This patient got surgery. Here's another example of a dissection. So this person was found incidentally, according to the chart, has a huge aneurysm, and you see a dissection flap here. There's multiple ways that dissection can actually induce or cause AR. One is the direct interference, and the others are also just the dilation, even if the dissection doesn't go all the way down to the leaflets. But this patient has severe AR, and you need to examine it more closely. So here's the orifice on short axis, and here's the remainder of the aneurysm. If you actually measure it, this annulus is close to 3 centimeters. It's just that this thing is so huge that it makes this look normal. But the dissection actually doesn't get all the way down, but this is that STJ stretching open or stretching the leaflets and causing AR. And some things you cannot really tell on imaging. So according to the op report, there's no dissection that's extending down to the leaflets, but there's those fenestrations along the none and the left coronary cusp and a dilated annulus. So for some of these patients, someone particularly with a genetic condition like him likely, you can have unusual causes for AR. Here's someone with rheumatic heart disease. You see the restriction of the mitral valve. Less commonly, it can affect the aortic valve, but you see how it causes stenosis and then fusion along the commissures, particularly here and here, and then a central AR jet. This patient has AS with AR. Now, why do I keep harping on the LV volumes issue? So here's an example that kind of illustrates the point. So a 47-year-old female, this is particularly more relevant for women, prior reported history of bicuspid valve, history of AR, and then questionable pulmonary hypertension. This is that same eccentric that I showed you earlier. So her LV diameters were only considered mildly elevated. And if you do quantitation, you get moderate to severe AR. People kind of just followed her. So 6 months later, actually she went into heart failure, and now her EF is down. So what went wrong in the prior scan? On the prior scan, actually, her LV volumes were not that different than what they are here. It's just that this mild dilation, quote unquote, by diameters, is essentially misleading. It suggests that there's mild dilation, but in reality, she had a huge heart already then. So she ended up going to surgery, but the issue for LV diameters is people can progress without a huge, meaningful change in the ESD or the EDD. And then there's the reproducibility issue also of, do you measure it at the base, do you measure it at the larger section? What if the person develops more elongation and increased sphericity of the left ventricle, which happens more often in these AR patients where it becomes like a huge sort of football shape, where your LV diameter at this narrow section may not increase very dramatically, but your heart is actually getting larger. And in this study, as well as the other one that I'll show you soon, a lot of people can actually have large volumes. So in this study, 31%, large volumes above what's considered prognostically relevant, but their systolic diameter is actually still within the quote-unquote normal range for AR. So up to a third of patients, and this is particularly relevant for women, like I said. In the study that I showed earlier, we looked at this also, and people with large volumes but quote-unquote normal diameters were also about a quarter of the population, and they had a higher adverse event rate. So this is kind of where things are now, like I showed you earlier. And the question is, this is a lot of expert opinion, essentially, and 30 years of experience, but it hasn't been sort of validated or tested against a secondary test. So now that we have the advantage of MRI, we kind of were able to do this with Dr. Zogby. Well, he did it, I participated. where people had, same-day echo and MRI. And this is, there's people with AR, there's MR, and there's multiple other sort of subgroups within this large study. But essentially, when you apply the ASC guidelines, the 2017 ones, the concordance between MRI and echo is pretty decent, actually. So they're within one grade of each other at 95%. Exact concordance was 64%. The reality is, even on MRI, there's nuances and discussions about what constitutes significant versus not significant. So we use the current parameters to decide what's considered moderate to severe or severe by MRI. Long story short, the AUC of the algorithm to detect significant disease was still pretty good, actually. But as you see here, this is a blind outcome of the regurgitant volume quantitation. So, the algorithm has a whole lot more than quantitation. But if it's just quantitation, there's no systemic bias to where echo over or underestimates the regurgitant volume by MRI, but there is high variability. So you can be off by up to 30, 40 cc's. And this is where doing this and more and getting more experience with it can improve this. But the reality is some of the challenges with echo can be tough to overcome, and this is where newer approaches can be helpful. So what we found was essentially some of these parameters that I showed you earlier actually have more value than others. So as you may suspect, pressure half-time wasn't really good, but vena contracta width and LV volume was actually much more accurate for determination of significant versus mild disease. And then the pressure half-time up to 700 or at a threshold of 700 can detect mild disease, but in reality, this is a very small minority of patients. So this is why you shouldn't really go by pressure half-time on its own to say, oh, this is mild or moderate or severe. And then what we came up with is a small and minor modification of the existing algorithm, but the focus here is trying to give more weight to some of the parameters compared to others. So the major ones that you should go by more and more often are the vena contracta width, jet width, now it's at 40%, and then LV dilation. And here we have a specific number for LV dilation where this is considered moderate to severe dilation based on the current echo guidelines. So if you actually have just these two, so either jet width plus volume or vena contracta plus volume, that actually takes you all the way to determining significant AR by CMR without you having to do all of this. It doesn't mean that you shouldn't be doing all of this, but when you have two parameters, dilated LV with a big jet, you can essentially take it to the bank. Pressure half-time on its own is so-and-so, like I said. And then flow reversal in the aorta, the challenge is that it has confounding factors. Aortic compliance, ventricular diastolic pressure, and ventricular stiffness, and then your ability to actually capture it, particularly with PISA. So, like I mentioned, even in the highest volume centers of PISA advocacy, their rate is 60 to 70%. In this study, because it had a huge number of people with bicuspid valve and eccentric jet, we only were able to measure PISA in about 40%. So a parameter can be very good, but if you can't really capture it or measure it, it's not so helpful. But when you can measure it, it actually is very accurate compared to the others. It's not more or less problematic. You just have to have it. And then for moderate to severe AR, you use a vena contracta width of 5. The threshold for LV dilation here is a little bit lower at 82, but essentially this is actual dilation that you can measure. Cleveland Clinic did a study kind of looking at the same question. They used a series of patients who had an echo and MRI within 3 months, and then they used MRI as the reference standard, looking at flow reversal on MRI as severe AR, and they had a high feasibility of PISA, but they also did regurgitant volume by Doppler, just like I showed you earlier. And essentially, they found actually the exact same number for EDV more than 93. So LV dilation plus PISA or Doppler quantitation of 45 can also take you all the way to severe AR without you having to do all the other parameters. And then they tested it against also reverse remodeling and then against the current ASE criteria. their AUCs were lower, but the challenge is they only included moderate to severe AR or greater. So you're testing the algorithm's ability to differentiate severe versus moderate to severe. That's not as helpful, so the results will be lower. But if they had included mild to moderate, I bet you all these numbers, whether it's ASE or the algorithm, would be much higher. So think of LV dilation as well as jet characteristics.
On that 93 number, was that contrast echo, non-contrast echo?
They actually reported that they did 3D and 2D and contrast when feasible, but the number they used at the end was just the non-contrast echo. Yeah. They didn't. It could be, and I think, personally, also, this number is also modifiable by the chronicity of AR. It could also be modifiable by the age of the patient. We know older patients don't dilate as much. So I don't think this is, holy grail number to go by, but it's a nice indication to use. And then once you're, in the mild dilation category, 80s or higher, it should really raise red flags. So it doesn't mean that if you get 92 that, this is not severe. But yeah, I think we need to look at this more. I think especially with serial studies, people can dilate more at the same degree of AR. You just have to follow them over time. All right, so in summary, you should always comment on the mechanism, severity. Unfortunately, you can't use one parameter. You have to look at all, but you may have to give more weight to some parameters, particularly the vena contracta and LV size. You have to optimize these measures on the acquisition as well. And then you have to practice these measurements, and you have to make sure all of your findings are concordant. You can have, your biplane LV stroke volume be highly different than your LVOT stroke volume. So these are our ways of making sure that our measurements and acquisitions make sense. And then you have to look at what's happening to the left ventricle, potentially other chambers. And then if you're doubtful or you're unsure, these patients need to be, are better served by getting more testing, okay? So volumes are now more emphasized, not just for decision making or when to operate, but you should also use them for diagnosis. Questions? All clear?
So, let me pose a question. Kind of the current numbers that we're utilizing to kind of identify significant or not is kind of being applied to all patients.
Yes.
So,
yeah.
There's probably a big difference between a 50-year-old bicuspid male versus a 75-year-old female with a degenerative trend valve.
Yes. Yeah. Yeah.
So how do you?
Well, I think we're going to work on it. But I think the, regurgitation severity-wise, we had looked at it from the small subgroup that we had in the MRI study. For older individuals, the regurgitation volume and fraction parameters that correlate with outcomes are actually indeed lower than what you have for younger patients with bicuspid valve. So you've all seen these people. Someone with a bicuspid valve can have 60, 70 cc's of regurgitation for 10 years and be fine. Whereas a 65-year-old with hypertension and diabetes may not. So the onus here is a little bit more on the clinician to look at these numbers subjectively and look at the patient. But I do think severity of regurgitation may be actually different for different phenotypes. When it comes to the remodeling extent, the same applies, it seems, where the ESV thresholds for older patients and women do appear to be lower than it is for younger men. So that 45 number we always used for end-systolic volume appears to be closer to 40 or 35 based on recent data for women as well as older men. So it's the severity plus the remodeling. I do think they may be different.
So I wonder if on the echo where you got multiple different parameters, you're trying to say, okay, I want 3 or 4 of these parameters.
Yeah.
A sliding scale.
Yes.
Based on kind of the underlying phenotype of the patient. So maybe choose. I'm just wondering if we looked at this, maybe.
Yeah, if you have.
An older patient that's a female, maybe 2 criteria even under that.
This is yeah.
Versus
Yeah, I think, it would be important to actually try to do it that way. I think the The challenge is, at least for this study, is we don't have as many. So if we look at it against clinical outcomes as opposed to MRI findings, and you have a large cohort of all ages and the two genders, it would be actually a worthwhile effort, I think. Yeah. But yeah, we haven't done that. Yeah.
So in these studies that you showed, these validation studies, what was considered a significant fraction based on CMR? Like, what was considered severe? Like
For this one?
Yeah.
Here we use the current numbers. So we gave a little bit more weight to regurgitant volume, but as you know, reading all these scans all day, someone can have a regurgitant volume that puts them in the 3+ category, but their fraction puts them in 2+, and then vice versa. So we gave more weight to the regurgitant volume for these particular discrepancy cases, but otherwise it's the same numbers. So 30 mLs or 30% or lower is mild, and then 30 to 45, 45 to 60, and 60 or greater, and then same numbers for the fraction. But in reality, that we know that a fraction of 40% or greater on MRI is, for all intents and purposes, severe. We haven't done it that way at the time, primarily because was not really, it's still not considered, accepted standard parameters. But if you use this parameter, contract of 5 millimeters and then EDV of 82, this quote-unquote moderate to severe AR is effectively 40% or greater for the regurgitant fraction on MRI, in this study even. So this parameter essentially is what's severe AR by MRI. It's labeled here as moderate to severe, but that's based on the old criteria, essentially. So I think, we'll see when the next set of guidelines come out, and if Dr. Zongbi is doing them or not. But I suspect we may see some of this in there. Yeah. Anything else? All right, thank you, everyone.